I am going to be speaking in English, and then just to make it even more interesting, I'm going to throw in a Japanese word or two. How many of you work in healthcare? Oh, a few. Okay, great. And I bet every single one of you is a customer of healthcare, right? You're all patients. You've all had the wonderful opportunity to sit for long times in a waiting room, or waiting for your test, or to hear about a test. So I'm going to try and include all of you in this conversation. What I'm going to do is share a little about who we are, a little bit more. I'm going to share why Virginia Mason was the very first healthcare organization to look to a manufacturing process and system to help us improve healthcare. And then I'm going to describe how we went about doing it. I'm going to give you a very few slides about specific lean tools that we have found to be very effective in changing our culture. And then I'm going to just talk a little bit about what leadership looks like in a lean healthcare organization, and then finally wrap up with the outcomes, which is what's most important. How are we making a difference to our patients? So Virginia Mason is what we call an integrated delivery system, meaning we have both hospitals and clinics. We have 2 hospitals. One's about 336 beds. The other one, which we just acquired about 2 years ago, and they're just starting their lean journey, has about 225 beds. We employ over 1,100 physicians and about 8,000 employees. We are a training institution, and we have where I work now is what's called Virginia Mason Institute, which we started up in 2008. Why? Because we were getting requests from individuals and organizations throughout the world to come and see what it was that we were doing in healthcare that was making such significant improvements in such a short period of time. So we established the Virginia Mason Institute. It is a not-for-profit separate entity which is focused on helping other healthcare organizations change and transform the way they produce healthcare, because we do believe that healthcare is a production process. If you think about, any of you have gone to surgery, you check in, we put you in the induction room, we put you in the operating room, and maybe you're in the hospital for a few days. It is a production system. You're not a car, and so every individual is different. And that was a lot of our pushback, quite frankly, from our clinical people. How could you possibly apply a manufacturing system to something that is so human dependent? Because 80-90% of what we do in healthcare really boils down to you, the patient, me, the clinician, and let's help you figure out what you're going to do. But it can work, which I hope to convince you of. The Institute has 15 what we call senseis, the first Japanese word. Sensei means teacher. So what we do is teach and coach other healthcare organizations how to not only learn the tools of lean, but for us, what we believe is that's not enough. What you really have to focus on is how you're going to change your culture and how are you going to change the way you lead in order to transform healthcare. And we have over 300 years of combined experience. We have physicians, nurses, director of finance, across the organization experience that we are coaching and facilitating others. So just to tease you with a few what we call big dots in healthcare, these are some of the outcomes that we have been watching since our implementation in 2002. So with any business, you want, for a growth strategy, is to have happy customers, right? So we've seen an over 300% increase in the number of customers who are likely to recommend Virginia Mason as their healthcare environment. Real big cost in healthcare is what we call brick and mortar, the operating rooms, the procedure rooms, and we have been able to use a concept of Lean called setup reduction to reduce the wait time between one procedure and another from over 60 minutes down to 10 minutes. Not only are we able to use our expensive resources better, but our surgeons are happy. And I actually started out in management dealing with surgeons, and I learned very quickly surgeons are not happy unless they're in the operating room cutting on somebody. So you want to keep them happy and get them in the operating room. And from a revenue perspective, quite frankly, in the US, as crazy as our health system is, that's a big revenue stream for us. That's really where we make our money. All the time, we are now considered one of the top 1% of the hospital, actually named one of the top 50 hospitals in the United States out of over 5,000. And for the 15th year in a row, we are the only organization in the United States who's been named a top patient safety hospital for 15 years in a row. So why did we do this? Why did a bunch of doctors and nurses who are executives decide that we wanted to go out and think about a completely different way to produce healthcare? Well, we have to turn back the clock. The year 2000, we had come off, quite frankly, a decade of bad financial performance. The previous 2 years, we were actually operating in the red, meaning we were losing money. Our board really didn't know whether we were going to survive. The board is a publicly held hospital because we're not-for-profit. And a couple things happened. The CEO that had been leading our organization for 20 years stepped down, and we had a new CEO, Gary Kaplan, who was a general internal medicine doc, who'd been in a newer culture and knew that we had some challenges and some things to improve. So he led the executive team, and there was 32 of us, physicians, administrators, et cetera, who went on a journey to look for something different. And it was great to talk to Zohar and Kalani yesterday. We're all in the same mindset that yes, there is an improvement method. You can call it Lean, you can call it GE Six Sigma. You need to have a process improvement, but that wasn't enough. We experienced that in the 80s and the 90s with different process improvement. What we needed to really focus on was the human dimensions of change. Behavior. It's not enough to create standard work. It's not enough to say we're going to do it this way. It's not enough to tell people this is what our top priorities are. You have to understand and work with the individuals to help them focus on the behaviors that need to change, which is hard. You know, you're going to tell me, who's been a nurse and my clinical specialty was urology, that I have to do a different way of producing, say, inserting a Foley catheter. I was an expert in inserting Foley catheters. Urology was my background. And you're going to tell me I have to do it a different way? No way, right? If for no other reason in healthcare, because we're so defect prone, every single one of us clinicians had enough experience of hurting patients, and we didn't want to hurt them anymore. So we set up our own system. But then we had to get people to understand that we're going to do it this way. So it was huge. So we realized that we needed to do some setup, if you will, before we actually applied our management method. We didn't even know what the management method was going to be at this point. The first thing we did was create a shared vision. This is our strategic plan. We created it in 2001. Purposefully, it's all on one page, with the intent that every single one of those 8,000 employees knows where we're going and how they're going to get us. And I'm going to share some more information about that. So we decided to put it all on one page. Every single word is selected very carefully. But because we call it a pyramid, but it's really a triangle, our board asked us, well, what's at the top? Well, and of course, us clinicians said, well, of course, it's the patient that's at the top. And our board said, well, I really don't think the patient's at the top. The patient's at the top, your systems and processes would be developed around me. I rush through terrible traffic and come to you and have to sit in a waiting room for 30 minutes, 60 minutes. Your systems are developed around you, the doctor, you, the healthcare. So we had a good discussion and we decided, yes, we're going to put the patient at the top. And that really helped us think about every single program and policy change, what's really the right thing to do for patients. Now the management system, what we call the Virginia Mason production system, we didn't have yet. We started looking for one, and we decided it was going to be a management system. It wasn't Cathie Furman who was leading the quality and safety that was going to do process improvement over here. We were looking for a system that everyone, whether you're the chief financial officer, whether you're a physician, whether you're the it had a supply chain, everybody was going to use the same system. And so we went looking. First we looked in healthcare, we couldn't find anything. We went to the top names, Mayo Clinic, Cleveland Clinic, you might have heard a couple of those. They weren't doing anything different than we were. So we worked with a consultant. We're very lucky to have Boeing in our backyard. You've probably heard of Boeing. And they had started on their lean journey about 10 years before us. And we started working with somebody who led their lean office, and one of the vice president who actually ran the 737 moving line joined our board. So that's where we decided to go. We started looking at manufacturing companies. We started studying. Here's a bunch of executives. Again, nurses, doctors, accountants, practicing on, in those days there weren't cell phones. So we had to practice stopwatches. And we had to draw out our standard worksheet, et cetera. So we were practicing, we're studying. For 18 months we did this. And finally, we decided we had to go to Japan. And as Zohar said, it was interesting going to Japan. It was the best thing we ever did because as executives, we were used to asking a lot of questions, but in Japan, nobody understood you. So you had to really practice big eyes, big ears, and a small mouth. And we spent a week at the Hitachi air conditioning factory. And I was one of 4 groups that were working in Hitachi at the time, and we were very proud of ourselves because here's a bunch of nurses and doctors, and we actually made more improvements to our line than the 3 other groups who were manufacturing who had come to Japan to learn the method. So we thought okay, this works. Even if you're a nurse, you can use this method to improve healthcare. And most importantly, when we looked at the philosophy of the Toyota production system and compared it to the Virginia Mason strategic plan, they're very much aligned. Obviously on the left, you've seen our strategic plan. On your right, I guess, that is taken completely from the Toyota production systems philosophies. The only word we changed was the word patient instead of customer. So we said, okay, we think we have found our way to change the way we produce healthcare to be safer and improve quality. But that wasn't enough because again, there's that human element in healthcare. 80 to 90% of what we do is human, right? We don't have the luxury of having a machine and changing widgets and change over time. We have to work with the humans. Wish we could figure that out, but no, we still have humans. So we had to align expectations, and I don't know how much this is the same in Israel. We work with, this is the 23rd country that we have been working with, and so far it seems to be very common that starting with the physician group, there needed to be some alignment of expectations. They're trained to be autonomous. They're trained to have a sense of entitlement, quite frankly. And they expect the organization to give them the patients, to help them with administrative stuff, and then leave them alone and let them do whatever they want. Does any of that sound familiar to you? Yeah, right. So Gary was very smart and said, we have to get the physicians on board. So while we were looking for a management system at the same time, we were actually, and this is not something the executives did, we actually asked the physicians to tell us what they think the organization's responsibilities were and what they should provide to the organization. That document has been a living, breathing document since the year 2001. It's really helped us with conversations when behavior is not what we want it to be. We use it for recruitment, we use it for evaluations, and whenever we need to have a conversation about not following standard work or whatever, that's what we use. So that's been very helpful. Soon afterwards, we did one for the leaders as well, and the board compact. So again, like Toyota, we wanted to focus on quality and safety, because as they believed, there's a business case, we believe, for quality. If you provide excellent quality and safety at a reduced waste, the revenue will come, the margin will come. This meant embedding mistake proofing, which in healthcare, for those of you who are not healthcare background, we do a lot, we harm people. How many people know that? How many people have had an experience where you've gotten the wrong prescription, it was somebody else's prescription? How many of you had showed up for an appointment and only to find out that they thought your appointment was the next week or the next day, right? And hopefully you haven't actually been physically harmed by having the wrong surgery or the wrong procedure, but that also happens. So we absolutely had to fix and improve our defect rate, which meant that we had to change our culture, because in healthcare, it is a long history of being very hierarchical. The doctor knows best, no different than commercial airplanes. And if in the old days, if a surgeon was going to operate on the wrong side, the surgical technician, even though they may know that the doctor is wrong, operating on the wrong side, would be too afraid to tell the doctor that they're operating on the wrong side. So we had some major cultural changes that we needed to make, and that requires leadership. So my breakout session, I'll be talking a lot more detail about what we call the patient safety alert system, which is how we stop the line. In order to stop the line, in order to understand what systems and processes are getting in the way of our people when they're trying to do their best for our patients, we had to engage our staff. So what we talk about with the Virginia Mason production system is top-down, bottom-up. As an executive team, we were responsible for setting the priorities, a few priorities in healthcare. There's so many opportunities, we would often choose too many, and then the staff would be overwhelmed and didn't know what to focus on. So we chose a few priorities. We established the resources, the money, the time to work on those few priorities. As leaders, we then frame, this is what the problem is, and then we get out of the way of staff, who are the ones who actually do the work. It's been a long time since I was actually an inpatient nurse, and I have ideas about how it might be better. People who do the work every day that can improve the work. So that means the commitment, and which was a big change in healthcare. And I don't know for you, but to carve out time for a neurosurgeon and nurses and physical therapists and whomever is working on the spine value stream to come together for a week and work on their work separate, their time was protected so that they could work on improving and reducing the waste and improving the quality and safety. And that's what we call a rapid process improvement workshop. And the great thing from a culture perspective is that people who had worked in our organization for a long time, doctors who had seen the face of the nurse for maybe 15 years and was at this point too embarrassed to ask what his or her name was. All of a sudden, when you get them all in a room for a week and they're working together, that really helps with the teamwork. In order to do that, we have focused and mandated, since we started our journey, to teach everyone within 2 days of their arrival at Virginia Mason to learn the basics of our management system, which we call the Virginia Mason Production System. That's at new higher orientation. Anybody can go on and do general education. We've broken this down into module format now. We require anybody from a supervisor, frontline supervisor, up to an executive must complete what we call Virginia Mason Production System for Leaders. And depending on what level of management they're in, if they are a director or above, they are required to complete certification, which is another 18 months worth of training, for a total of 3 years of training. So they're deeply trained in our management system. Why do you think that is? How can you manage if you don't know what the management system is? How can you apply what we're trying to do unless you're deeply trained? But it's a different type of leadership. No longer was I, when I was a leader, and in healthcare, for those of you who don't know, I don't know if it's the same in manufacturing, people who are technically very good at what they do, I was a great nurse. Sorry, I was. And so I was asked to be promoted to be a manager. Now, I didn't really, you don't learn in nursing school how to manage. You don't even know what you're supposed to do, necessarily. But I could go out and be Wonder Woman, Gal Gadot, right? And if somebody had a problem, I could say, oh, I've seen this one before. This is how you do it. But it was very much a telling the people how to fix it versus stepping back. What we do now with our management system is we frame the problem. We need to fix X, Y, or Z. Don't know what it is. You tell me how we're going to fix it, because I don't do that. I don't take, I don't do medication pass in the hospital anymore. So, and it can be different ways. So that's why we do the learning. And we have, I believe, much of what Zohar said, 99% of it I didn't understand. But we use what's called everyday lean ideas. So if an individual has an idea for improvement, we don't have to have a huge 5-day workshop. They are all wasteologists. We we train them, they apply the scientific method, and if an example, one emergency room tech nurse was concerned because the medication that they use all the time in the emergency room for nausea, you know what nausea is? Throwing up, was way down in the bottom drawer of the medication cart. And so they were constantly doing this. And so they said, so they measured it, they used their tools, and said, this is how many times we're coming down here, and I have an idea. Let's just put it in the top drawer. Save time. Very simple. They collected the data, they went to the pharmacy, said, pharmacy, can we do it this way? And the pharmacy said, sure, no worries. So those are the constant, fast improvements that are happening all the time. So we train our staff, we focus on culture change. Now I'm going to get into some tools of Lean that have been significant for us in healthcare. One is waste. Every single nursing staff group that I have talked to in every single country feel that they don't have enough staff. And that may be, depending on it. But our perspective is there's lots of money in healthcare. It's that we're wasting the money in healthcare. We are wasting people's time. So the concept of waste, Taiichi Ohno, who was the inventor of the Toyota production system, said if you do nothing else, focus on relentlessly removing waste. The waste of, how many of you have been in a doctor's visit or in the inpatient stay, and the nurse or the doctor is constantly going in and out because they don't have what they need, right? All of that is waste of movement. How many of you that have an experience in healthcare or perhaps even other industry, I don't know if they do this in other industry, I've only worked in healthcare, we throw out hundreds of thousands of dollars of medical supplies because they've expired. Same with drugs. It's a waste of inventory. So if we focus on waste, which we have done significantly, and waste we define as any task or item that does not add value. So there's a lot of things, quite frankly, that I would do as a nurse or the doctor would do that they thought was adding value. But from the customer's perspective was not. So we worked on a pancreatic surgeon, very nationally known, wanted to do some improvement on the way they remove the cancer of the pancreas. The pancreas is a life-saving organ that produces insulin. And I actually was, as being an executive, I had to continue to be certified and lead workshops. And we had patients on our workshop. And he was so proud. He as a doctor felt very like he was really doing the right thing, because when he met with his patients, when they had the diagnosis, he would describe for an hour what he was going to do to help them. And as part of this workshop, he finally heard for the first time from his patients, we had a couple of them, after you used the word cancer, I didn't hear another word you said. So he thought he was doing the right thing, but you have to listen to what the patient wants, right? We also, this is the one thing that is completely designed by Virginia Mason, because we had to adapt the flows of the manufacturing process to those that made sense for medicine. So for those of you who know a little bit about Lean, you look at a process value stream from the time, the beginning to the end. And yes, the patient is experiencing whatever that is. Let's say it's an orthopedic value stream or a clinic visit. But how do you incorporate at no waste, just in time, with just the right amount that supplies the information? And again, I'm going to be speaking about this at the breakout session, about how we have applied mistake proofing as part of this. And it was a huge cultural issue for healthcare. As I had mentioned before, it was not only scary, it was often unsafe for a nurse or even an anesthesiologist to tell the surgeon that they were making a mistake, because they would be berated, yelled at, screamed at, and maybe not get a job, right? If they were a teaching person. So we had to do some major cultural changes with this. This is the other tool, if you will. Have any of you heard of what's called world-class management as a lean tool or strategy? Couple people. We didn't learn this until about 8 years into our journey. And the concept is how, if you're the CEO of a company, how do you make sure that everyone in your company understands where your company is going and how what they do on a daily basis impacts where you're going? So this is all about aligning the vision, the annual goals, down to the department, and then to the individual goals. And so what we do now for the last 5 years, I'll give you an example. Again, I'm a urology nurse, so I always use urology examples. There's a problem in healthcare called infections, right? We give people infections. They're called healthcare-associated infections, and sometimes they die. Most of the time they don't. There's a particular infection called a catheter-acquired urinary tract infection. And we were not very good at it. It was not an area of focus for us for years. But we had a goal to eliminate healthcare infections. So I partnered with our chief nursing executive and hospital administrator and the Lean office to use as one of our quality metrics catheter-associated urinary tract infections. We produced, the infection control department that reported to me would then give to every single hospital floor what their rate of infections were, what their rate of hand hygiene was. And as part of the world-class management is this concept called daily management, where every day, twice a day in the hospital, 7 a.m. and 7 p.m., they come together to understand who's working, who are the patients, what any issues that we have. It's called daily management. And so if I was a nurse on med-surg floor, I would understand, I'm going to come in, I've got 5 patients today. Of those 5 patients, 2 of them have an infection, have a catheter and are at risk for infection. My job, because it's one of our goals for the organization, is to reduce infections, is to work with the patient and perhaps the family to talk them in to having that catheter removed, because a lot of times patients don't like those catheters out because that means they have to move and they hurt. So anyway, so that's how we work that out. And then my performance evaluation, if I'm the nurse, part of it is how well did I do at that goal, right? So every doctor, every nurse, every accountant has a goal tied to the organization. With daily management and leader standard work, we had to become very explicit about what the leader's job is. The leader's job, whether it's in a small group of 5 or in a division of 500, their job is to run their business and improve their business. Now, it might seem a little surprising, but sometimes we had to actually figure out what the business was in order to run it and improve it. A good example is, the reason why you need to know is because you need to understand what are the metrics that you and your team are going to be looking at every day, right? So we got really explicit about your job every single day, if you're the leader, is to understand what is your demand, what is your capacity, and how you're going to improve that ratio in order to meet the demand, because the demand is the money, right? The demand is your mission, which is to take care of patients. This is what we call a production board, and this is in a clinic. These are how many doctors we have. These are this is our demand. And then the team meets in front of this board in a clinic 3 times a day, in the morning, at noon, and midday, to adjust the demand, the amount of workers to the demand. We require our leaders to report up and down. And remember, it's a top-down, bottom-up. So this is a structure of what we call tier reporting. The executive team and the board gets reports at the big level metrics to understand how's the business doing on a monthly basis. Each frontline supervisor meets with their team every week to review what's the organization focused on, how does that relate to us and our team, and how are we doing. This is just an example. We call it People Link. So it's a way in which to engage the staff in understanding the business of the organization and how they can improve the business. The other thing that we became very clear about was accountability. This is just an example of us walking and seeing, looking at the processes. As a leader, again, the Wonder Woman type leader, I would come in and I would figure out what I was going to do for the day. And I would go around and chat with people. I would go out and I would talk to my team, but I might ask them, how's your children? You know, what'd you do on the weekend, trying to be social? But there wasn't anything structured about it. So with daily management and standard work for leaders, we were very explicit. This is the agenda that we expect. This is particular one is for the inpatient, and this is what the chief nursing executive does on a monthly basis. When I was the senior vice president for quality, I would go out every Thursday at 10 o'clock. I had different people that I would see at 10 o'clock on Thursdays, but we would run through this. And what were we running on? At the beginning, when we were designing our annual goals, and my leaders were saying, this is what processes I was they were going to improve, and these were the metrics that they were going to improve. This was to check, okay? Have you done some improvement work on this? What are the metrics looking at? What are the barriers, if there are barriers? Because my job as an executive was to remove those barriers. So it's a very structured conversation with my leaders. This is not with the staff. This is my leaders. So say the director of infection prevention. Okay, you were supposed to implement a new surveillance system. How's that going? How many, you need to understand the process before we do technology, right? So what kind of Kaizen events or rapid process improvement workshops have you done to prepare for the technology? Those kinds of things. So here's some big dots in a nutshell. So does it work? Yes, we're 15 years into it. Remember I said we were in very poor financial situation when we began this work. This demonstrates the effectiveness of the safety program, which again I'm going to talk about at the breakout session. The green bars represent the number of patient safety alerts. These are people who are pulling the cord and saying, this is an unsafe situation, or we have a broken process. As those have gone up, there's a tight correlation for the number of claims and lawsuits. Now, the U.S. society is a highly litigious society when it comes to healthcare, and I don't think it's as significant in this country, but this is dollars to the bottom line, because we were self-insured to a certain, to about $5 million a year for hospital professional liability. These are the number of quality awards that we have gotten, again, consistently over the years. I mentioned one of the 50 best hospitals, Patient Experience Award, top hospital of the decade for safety, etc. This was actually a completely staff started and run, which is they're very interested in saving the environment. So they've done a lot. We're now one of the 50 greenest hospitals in terms of waste, etc., in the United States. We have to have happy customers. That's our main objective, is to ensure that patients are happy. This is the likelihood to recommend, both in the clinic and the hospital. We're continuing to see it. This is the actual professional liability premium story over the past 14 years. We've seen a total of 75% overall reduction in premiums. That's about $5 million that has gone to the bottom line. We now pay more for workers' compensation than hospital professional liability, which is unheard of in the United States. And here's our economics. So since the year 2000, we have had a positive bottom line, continues to grow. 2009, this big spike was because we were doing so well from a defect reduction and improving quality, we were able to take down what we call reserves that we had planned for claims and lawsuits. So we were able to just put that to the bottom line. Most importantly, the yellow horizontal bars is what we call our shared success program. If we make a certain amount of money, our board says it's okay to give back. So every single staff person gets a separate and distinct check from their paycheck. And some of the, for the higher compensated people, it's not that much. But when you give a check for $700 to a medical assistant or a patient care technician who's really living paycheck to paycheck, it's a really big deal. And it's a way to say thank you, to celebrate, to recognize, and to continue to engage them in our improvement, because we want every single person helping us understand where we need to improve. So this is our summary slide. It's an evolution. The main purpose of the slide, these are our clouds or opportunities for those of you who know value streams. It has not been a smooth upward trajectory from the time we got started in 2002. I'm here to tell you that it's not easy. There have been bumps in the road. What's important is to keep with it, to recommit that this is the way we're going to produce healthcare, even when there's difficulties. Thank you very much.